intrinsic stain or intrinsic stains, the dental fluorosis is coming inside this group. According to the Center of Disease Control, the fluoridation of the drinking water considered to be one of the top 10 of the achievements in the public health in the 20th century, concurred with decline in dental caries and increase in the prevalence of dental fluorosis. As you know, the fluoride is important for optimum oral health at all ages. It's made available at two surfaces by two general means, systemic and topical. And for a better understanding to the tooth color change according to the dental fluorosis, multiple epidemiological studies were being done, and the U.S. Public Health Service sponsored by 1930s and a study by multiple studies by Dr. Den, and conclude that the fluoride optimum water level for caries prevention average 1 part per million, and the dental fluorosis is associated with level more than 2 part per million. And the first U.S. communities were fluoridated in 1945. The absorption of the fluoride in our bodies came through two main ways, through the gastrointestinal tract and the bloodstream, and the distribution by plasma to all tissues and organs. Approximately 99 of the fluoride in our body located in mineralized tissue and in the type of the fluorapatite. The excretion of the fluoride go through the kidney and through the Sweet glands. The teeth can acquire the fluoride during 3 periods: pre-eruptive, mineralized stage, and maturation stage, and post-eruptive. The tooth surface fluoride, the fluoride in the enamel is the highest here on the external surface, and it will be little when you are going inside. And for the enamel, it's much richer by fluoride due to the rapid absorption. And by the cementum, it's also high once we have exposed cementum in case of the recession and attachment loss. The beneficial effects of the fluoride, as you know, mainly it's prevent demoralization by formation of calcium fluoride, and this formation will gonna enhance the remineralization of incipient caries once we have a drop in the oral mouth pH. So the fluoride will take care about this. It's gonna remineralize the demineralized tissue, and this equation to be kept with good oral hygiene and with fluoridated mouth rinse and toothpaste. Also, the fluoride is an enzyme inhibitor and can have a significant effect on the plaque metabolism. The unwanted effects of the fluoride therapy on the skeletal systemically, it's gonna cause the skeletal fluorosis, and this is concentrated mainly in the long bones. On the teeth, the excessive fluoride more than 2 parts per million will gonna cause dental fluorosis. And this is a result of the following actions: the excessive secretion of proteins or differences in their amino acid composition, inhibition of the proteolysis of phenol proteins, amyloidogenesis, which turn would prevent normal mineralization. Regarding the fluoride and the cancer, extensively were being studied, and up to now, this relation was not justified. For the overdose, we are following the WHO guidelines. As you know, the lethal dose of sodium fluoride is 5 milligrams per kilogram among the body weight. So we'll not prescribe fluoride until it's indicated. We're gonna decrease the amount of the traditional 2 milli of sodium fluoride mouth rinse to be used for preschool children to be half of the dose by 5 to 7 milli. And treatment of fluoride overdose in severe cases will be gastric lavage, and in severe cases, IV infusion of 10% calcium gluconate to balance the fluoride inside the body. The benefits of fluoridation in the permanent caries, we are talking about the studies right now. It's when being fewer caries, lesion by 40 to 65%, root caries the same, almost 50% less. And for the primary teeth, the same issue will be reduced to 50% in the primary teeth. And for the periodontal status, it will be improved by improved bone density, and indirectly by lack of retentive areas of bacterial plaque. The prevalence of dental fluorosis, is endemic or not? So it's a big question. Here in US, the prevalence of dental fluorosis, according to the American Academy of Pediatric Dentistry, it's almost up to 32% in 2002. And this can be attributed to increased availability of foods, beverage, toothpaste, and other oral care products and supplements. The group age, the highest prevalence was with the group age from 12 to 15-year-olds. And according to the CDC, the 23% of persons aged 6 to 49 had dental fluorosis. So the most of the fluorosis here in the US, according to the current data, is mild and barely solved by dental health, by non-dental health professionals. In my country, Saudi Arabia, we concluded that the fluorosis is present among 24.6% of the population. And this is mainly because of the rural areas are dependent on isolated well water. And our level were being found, the stage of the fluorosis in the questionable and very mild categories. And this brings a lot of questions, by the way. So we started our own new national study, where being sponsored by King Khalid University, Saudi Arabia. We are starting to recheck this again, since we have the risk factor is very high, by the way. For better understanding for the fluorosis stage and treatment modalities, the dental fluorosis indexes were being established. The historical one and the father of that is the Dean classification, which being used for multiple epidemiological studies. It's very simple, by the way, but the Thiel-Strab and Fidgeri-Skoff index is the more diagnostic, more sensitive. It's going through the histological analysis and give good treatment outcomes. The tooth surface index of fluorosis were being established for easing the diagnosis for the case once the fluorosis is the prevalent. And also the fluorosis risk index and modified development defects of enamel index were being also formulated to ease in the diagnostic procedures. And now, 2014, a lot of starting from 2012, but actually to find another way to better understanding of the fluorosis and better diagnosis, not to miss anything, by using the visual analog and also the quantitative fluorescence, and also for using the normal white light. So all of these is come with each other just to compensate the shortage in the diagnostic terminology and the diagnostic matters for the dental fluorosis. So please, I'm warning myself first that we have to go through the diagnosis of the fluorosis by a systematic approach, not to miss any other, diseases other than the fluorosis. The management of dental fluorosis, it will be in preventive measure, first line, and then the therapeutic measures. The preventive measures by defluoridation, by avoid excessive fluoride intake during the late secretory and maturation phase of enamel. It's between 3 to 4 age, 3 to 4 years of age for permanent anterior teeth. And the upper limit, according to WHO, the fluoride is supposed to be at or less than 1.5 parts per million. The controlled use of fluoride in preventive dentistry, here we are saying again, we have to look to the indication and contraindication before starting any supplements. Supervision fluoride toothpaste used in children by supervising the toothbrushing, and related to the age and the weight of the children, and also the maneuvers of spitting out the paste after finishing the toothbrushing. The therapeutic measures, we are starting with the minimally invasive procedures as much as we can. So we're going to start with the bleaching. The bleaching is indicated in very mild fluorosis, according to any type of index. So the best result we're going to come with combined in-office and at-home bleaching. This is case by Dr. Cloud, 2009. This is classical Vita C2, and we can see here it's now B1. So this is very effective. This is one of my cases. I used the double technique in office and at-home bleaching, and it's promising. After that, if this is not working, we're going to go for microabrasion. The microabrasion, now it's more promising because of the new material like Prima and like the Oblaster. This is for the mild fluorosis to some moderate fluorosis. And this is where being done by Dr. Howard, 2006. But what he did here, he used macroabrasion. We are trying our best to avoid macroabrasion due to the sensitivity and also the the end result will not be that promising. I mean, the roughness and these things. So we have to go, for example, here sometimes we need it to open the access for the microabrasion, and sometimes using microabrasion alone. This is a plaster material. And after that, sometimes we are using bleaching, even after that, if the sensitivity scale is not that much. If this is not working, we have to cover the labial and mask the labial surface, and this is for moderate fluorosis, either by composite or by ceramic veneer. So this case were being done by Dr. Shiraz 2014, and he masked all the area by composite, but according to Akbata 2014, with critical review on this, the composite is not that promising as porcelain laminate veneer, and it's going to cause a lot of irritation. Otherwise, also the bonding itself, we're going to have, it's not been studied well up to now. This is one of my cases, the patient with fluorosis, but the patient's chief complaint is just to close the spaces. So I close the spaces. I use the microfill. This is microfilled composite, and also I used hybrid composite in some areas, and it's not that promising, by the way. This is my case, but I know this is not the absolute or the excellent job for this patient. We are trying to keep and follow up. We're going to see if we're going to replace or not. And this is done 6 years recall case, were being done by Dr. Al-Jazairi 2001. This is very promising, and you can see this is after 6 years, by the way, by laminate veneer, porcelain laminate veneer. The full coverage is the last choice. We use this one when more than 50% of the labial enamel has been lost, or we have a severe fluorosis, or the other treatment modalities doesn't work. So we have to go in this choice. This is one of my cases. The bite and pitted and mottled teeth were be referred to my colleague orthodontist, Dr. Sommer. He did the job for the orthodontic treatment, and this is after orthodontic treatment. And this is my wax-up for the patients, and this is my temporary for the patients, and this is my final crowns, and this is ceramimeter restorations due to the socioeconomic of the status of the patients. So we did this, and this is the occlusal splint, and this is the lateral and left side. And also we have not to miss this issue regarding the etching time fluorous teeth. It's now well known that's the double time, the normal time, and a lot of study now also talking about specific time. The bonding to fluorous enamel and dentin, so the best thing and the best technique is total edge technique to use here. It's more promising than the other techniques. Thank you very much, and any question?